my talk today is about embolization for arteriovenous malformations, and I'll try to sort of stick to that as much as possible. So AVMs are congenital, we believe, almost always. They can sometimes be acquired, but when they're acquired, they typically tend to be more fistulous. They have three components. There are these dilated arterial feeders. Then there's a core of dysplastic vessels, and then there's arterial feeders, and finally there's a large red draining vein. The important thing to know compared to, say, arteriovenous fistulae is that there is no neurologic tissue which resides within the actual nidus. Although that is not entirely true for the more diffuse type of niduses that sometimes occur. There may be tangles of neurologic tissue that reside within, but for something as compact as this one, this is only nidus and nothing else. And so there's the drainage vein. So what do we know about arteriovenous malformations? We know that they have a risk of bleeding. Their risk of bleeding appears to be greater, significantly greater than the risk of aneurysms bleeding. So that's one thing we need to know. The second thing we need to know about them is they are much less frequent than intracranial aneurysms. But in terms of individual features for AVMs and bleeding, if they actually have an aneurysm on an arterial feeder, I believe there's considered to be higher risk for bleeding. Not so much so for venous aneurysms, which are frequently seen in association with these AVMs. Second, niduses. The opposite is true, where here the smaller nidus has a higher risk of bleeding than a larger nidus. And let's see, make it a little bit more interactive. Any guess from anybody as to why a smaller nidus might be at higher risk for bleeding compared to a larger one? So what's the, let me ask a question a different way. What's the reason that a nidus ruptures or an AVM ruptures? Anybody? Oof, tough crowd. Okay, you guys, you really want me to pick on you now. All right, let's see, the one person who's completely trying to ignore me here. Yes, any thought as to why AVMs rupture?
Probably the like smaller drainage and high pressure inside.
High pressure, you named it. So what's a high pressure? The high pressure is the differential between the arterial side and the venous side, right? And if you have a massive AVM, the amount of flow that it takes for blood to get from the arterial side to the venous side dissipates some of the pressure, because there's always compliance within the nidal vessels. They can enlarge, dilate. There's a capacitance that reduces that pressure. That's why smaller AVMs are much higher risk of bleeding, because they don't have that ability, and therefore their ability to degenerate over a shorter is faster than, say, a grade 5 AVM that's 6 centimeters. Another one is deep venous drainage. It's not quite clear exactly what the rationale for that might be, but it's been well established that deep venous drainers tend to bleed more often than superficial ones. But also along with that goes with the fact that AVMs that are deep-seated posterior circulation tend to have a more vigorous history. Venous stenosis, another, again, makes sense, right? The same pressure hypothesis, that if you have a venous stenosis, then you have an even bigger pressure drop, and therefore there will be a higher risk. And as I mentioned, deeper location is a risk. So 2 to 4% per year. The best part about Aruba, which was this recent study, and we'll briefly talk about this in a second, was that it gave us confirmation that we were spot on in terms of the natural history. It was somewhere north of 2% per year rupture risk. And so the equation we all use is 105 minus H. It works reasonably well. It doesn't tell you if a person's going to have one hemorrhage or multiple hemorrhages, but gives you an idea that at least once in their lifetime that might be the risk. The morbidity, mortality with each risk, with each event of hemorrhage remains relatively stable with about 10% mortality and about 30% major morbidity. So there is this concern of impending disaster which exists. So how do we make decisions? Surgical decision making has evolved significantly thanks to Dr. Spetzler and Dr. Martin and their sort of phenomenal sort of prescient sort of recognition of this grading scale, and that's become the mainstay of how we think about AVMs. And what we've realized is that there are the grade 1s and 2s which are going to do very well, and 4s and 5s you really want to stay away from, and then there are 3s, and the 3s that look like 1s and 2s should be treated, and those that look like 4s or 5s, well, maybe we can reconsider. So we have created this sort of scale where it really helps us think about AVMs in a unique way. So those grade 3s which fall on either side of the fence can be further divided. So you can think of size, you can think of venous drainage and eloquence. So if you have a small AVM with minimal sort of eloquence and superficial drainage, these can probably be approached like lower grade lesions. On the other hand, if you have a massive lesion, then the risk is going to be a little bit higher. Or large lesion in eloquent areas, the risk is going to be higher. So, and Mike Lawton, who's not here, I don't think, has he come in yet, has done a lot of work and refined this further with his ABC grading as well, that I'm sure he'll talk about. And then there are grade 4s and 5s. Grade 4s and 5s are the ones that, at least as far as natural history is concerned, we believe their natural history starts becoming slightly better than the operative risks for these patients, but not in all cases. And so the management strategy for 1s and 2s is very clear. You want to cure them. For 4s and 5s, the strategy starts becoming different. Maybe it's not possible to cure them without significantly hurting them. And so indications for treatment are maybe different. So if there's a pedicle aneurysm, well, maybe fix this aneurysm, leave the AVM alone. Volume stage gamma knife has been purported, and I was recently with Michael McDermott from UCSF and Doug Konziolka, and they are starting to come up with cure rates closer to 50% with morbidity rates less than 15% for some of these volume stage results. The problem is volume staging takes so long. It's a 10, 12, 15-year sort of period over which these lesions go down that the data is simply not there for robust support. So grade 5s and grade 4s should be ideally left alone unless there's specific reason by which you want to treat them, whether there is a major fistulous component that's causing steel phenomenon or aneurysms, etc. Or there are recurrent hemorrhages and you want to deal specifically with the region that you think may be causative. So how does this fit in with endovascular? Well, endovascular strategies, while they have a lot of commonalities with the overall surgical strategy, have specifically different sort of rationales for treatment. So we have tried to come up with our own grading scale for endovascular treatment of arteriovenous malformations. It hasn't quite taken off as much as the Spetzler-Martin scale, but that's never put us off before and won't do now either. So how do we construct the scale? And this scale reflects our thought process when we think of endovascular treatment paradigms. So the first thing we want to look at when we think of endovascular options is how many pedicles? Why? Because each time you catheterize a vessel to go into an AVM, you are exposing that patient to some risk. And by definition, endovascular requires multiple catheterizations because it's very rare that you just have one artery going to an AVM. So we expect that we'll have to go a couple of times, but if you have to go into an AVM 10 times to embolize this, or 15 times or 20 times, well, that's the nature of averages would suggest that you're going to run into some kind of trouble at some point. So the first thing, the most important thing from an endovascular perspective is how many times do you expect to get into this AVM and try to treat it? So you can have a low grade, which is 1 or 2 pedicles that you can visualize. Also know that what you see on an angiogram is a reflection of flow. So just because you think there's one pedicle does not mean there's just one pedicle. You might not recognize the other pedicles till you take that pedicle down and see the other lower flow states become more apparent. So sometimes it takes a while before you can really completely figure out all the sources of blood to an AVM. So, but it makes sense. 1 or 2 pedicles, it's a grade 1. 3 or 4, 2, and more than 5, that really starts becoming a higher grade lesion. Then diameter of arterial pedicles. So that's another important consideration. And again, it's not quite intuitive from a surgical perspective, but from an endovascular perspective, it's of vital importance. Why? Because catheterizing really small pedicles is a higher risk procedure compared to larger diameter pedicles. So if you have large cortical feeders going to an AVM, those are much easier to catheterize and to treat than, say, lenticular striate perforator feeder going to a deep AVM nidus, which is small. And so that also sort of changes your perspective. So more deeper AVMs that have small perforator feeders would be higher risk. And finally, eloquence. Obviously, complication that occurs in eloquent cortex is going to be more consequential than non-eloquent. So that's how sort of we develop our grading scale. Again, trying to keep it relatively simple. So how does this vary compared to a Spetzler-Martin scale? Well, grade 1s are pretty simple. Grade 1s look like grade 1s. I believe grade 2s can be a little bit different. So not all grade 2s on the Spetzler-Martin scale are going to be grade 2s in the endovascular scale. In fact, most grade 2s on Spetzler-Martin may behave more like grade 1s on the endovascular side. Okay? It's the grade 4s and 5s which tend to have a lot of commonality in both grades. But not all grade 1s are equal, not all grade 2s are equal, but you can start appreciating that depending on what strategy you're going to employ, there are commonalities. So we looked at our multivariate analysis, and what we found was that we could really start looking at the risk of these through multivariate analysis. And what we found was that grade 1s and 2s could be much more easily obliterated at higher cure rates and lower complication rates. 4s and 5s, very low cure rates, much higher complication rates, very much similar to the Spetzler-Martin scale. And so that has really, we evaluate AVMs in always a multidisciplinary sort of situation. I'll share that as we go through this talk in terms of how we think about it. Now, moving on, I think imaging modalities are changing the way we evaluate AVMs. There's certainly diagnostic angiography, MR, and CT, but there are new measures as well. So here's an example of what we call parametric imaging. So what it does is it color codes diagnostic angiography and does that live and allows us to very clearly identify the major arterial feeders. Allows us to evaluate the efficacy of embolization as well, because we'll see the color code change post-embolization, where there'll be a little bit more delay on the vein, or area of the blood supply will sort of change from, say, a red to yellow or yellow to green, and will allow you to appreciate at least in a color-coded fashion, compared to a simple diagnostic angiogram where you may not necessarily appreciate it as much. Second, you can do that with MR as well. So there's 4D MRI. What is 4D? The fourth dimension being time. So a time-resolved MR that allows you to appreciate what's the first thing that gets into AVM and allows you to maybe understand pedicle behavior much better than ever possible on MRI. So I think that certainly allows you to appreciate, as in this panel, what's coming in first and what's coming in last. Finally, perfusion imaging. So how do you establish steel? Well, the way you establish steel could be just clinical phenomenon. The patient's having some steel-like phenomenon, but to be able to show that, we can do that with perfusion imaging. So you can see that in the peri-AVM adjacent cortex, there appears to be reduced flow and volume because the blood's just getting sucked away by the AVM, and that can help sort of allow you to say, okay, the steel's coming from here, so maybe this is the pedicle I need to target. So there's some fairly advanced imaging that you can do to help you. So how do you describe the treatment plan? I think it's really important to understand the high-risk features and the risks that are associated. So what are the major risk factors by which I think of risk? I think of direct fistulous components. So that's one that endovascularly can be easily addressed, rapidly addressed early on. Prenatal aneurysms should be considered for treatment, especially if they're given size. If they're relatively small, you can leave them alone, but if they're starting to have irregular features, large size, secondary excrescences, one should consider treating them first. Venous varix is not that important unless you do a major subtotal embolization. I'll share an example of that a little bit later. And then start planning on embolization. How do you go about it? I try to go for the largest arterial pedicle I can find. That's the way I go about it, the largest one. You could say, well, if you're going to go to the OR and you can occlude that right at the time of surgery, certainly that is possible. I'm the guy who's going to be taking this out. I like my AVMs to behave like meningiomas. That's when I'm happiest, is when they behave like meningiomas. There's no stress. There's not a lot of blood loss. It's a great case. The resident are doing most of it. There's hardly any screaming involved. On the other hand, if it's a live thing and it's bleeding because it's barely never embolized, it's a little bit of a higher stress situation. And after about a decade of doing this, higher stress situations are just not quite as appealing as they were 10 years ago. So I do try to embolize vigorously and aggressively, but there is a rationale for surgical planning. So the ones that you need to embolize the most are the deepest pedicles from a surgical standpoint. But let me give you another example of that. So say you've got a cortical-based AVM that goes all the way down to the ventricle that has a few lenticular striates that are feeding it. So you could say, well, from a surgeon's perspective, if you nail those little what will become red devils at the end of the case, embolize the lenticular striates will make a lot of sense. However, the embolization risk of those lenticular striates is higher. I'd rather deal with a small red devil at the end of the case than potentially have a pre-procedure embolization-related infarct because of occlusion of a lenticular striate. So you have to weigh and balance. It's not straightforward. By the way, there's also a grading scale from a radiosurgery standpoint, and that's simpler, but it works. And you can imagine what that would be. It's got to do with volume, because volume is the major factor when it comes to gamma knife radiosurgery. And so a small volume AVM can be very easily treated with gamma knife, no matter where the location is. Location does help somewhat in terms of basal ganglia or brainstem. Why? Again, because of the ability to tolerate radiation. So you can come up with an AVM score based on this Pollock-Flickinger scale. But the treatment option ideally should be considered in a multidisciplinary management, or sometimes in just one person. So I do the gamma, the embo, and the surgery, so it's sort of more straightforward in terms of thinking about it. But in most places, you have a team approach, and I think that is a very reasonable way of going about it. So what are the options? Microsurgery, plus minus intraoperative angiography, stereotactic radiosurgery, or embolization, or all of the above. That includes embolization followed by microsurgery, embolization followed by radiosurgery. And this latter is typically what I would do unless the AVM is of a variety that's fed almost entirely of en passant vessels. So if you have a major AVM supply that's all en passant, there's no direct feeders into the nidus, well, that's the one where you either just directly go for micro or directly go for gamma. But if there are direct catheterizable supplies to an AVM that you intend to treat because it's a grade 1 or 2 based on the endo or Spetzler-Martin scale, then we try to go with embolization first. The goals need to be very clear. What are you trying to do? Are you going to go for a cure? We rarely go for a cure unless it's very clearly one pedicle, 1 or 2 pedicle. Our goal is almost always multimodality management, so embolization followed by surgery, embolization followed by radiosurgery. What is the goal? Are we trying to treat an intranidal or feeding pedicle aneurysm, preoperative embolization, cut blood loss, deep feeders to facilitate surgery, pre-radiosurgery? Pre-radiosurgery matters because you can't just willy-nilly take pot shots. You want to try to bring the overall volume of the nidus down. That's really important. If you cannot cut the total volume you're going to radiate, you've done nothing to help the patient. And that's partly, in my mind, the reason why embolization and radiosurgery have not been very well established, because most people are just spitting in the breeze all over the place and the overall volume of the nidus is no different. So what is unclear is just partial targeted embolization of AVMs improve natural history. I would say the answer to that is no. In one sense, where in terms of overall rupture risk, but I think in grade 4s and 5s, I think it may be useful to avoid Steele phenomenon, to reduce risk of rupture from an aneurysm, etc. So, assessment of embolization. It's very difficult because people have used a lot of stuff to treat AVMs: coils, glues, onyx, gel particles, PVA particles, gel foam. So that's been different. The second thing is the catheters continue to evolve. Although I would say over the last 5 years, embolization techniques have stabilized. So we are typically now using similar catheters, onyx and BCA, and it's stabilized. Also, embolization is very different depending on what part of the world you're doing. So you're more likely to go for a cure, say, in Turkey or Hungary, compared to France, where now you're not going for a cure at all unless there's a rupture status. And in the US, almost always it's in an adjunctive capacity. So what are the agents that we use? We use embolic agents. NBCA has been around the longest. We have the greatest experience with it. We are relatively limited in terms of its ability to inject over long periods of time because it tends to glue and stick, and then your catheters get stuck. But you can certainly use it with a detachable tip catheter, planning to have part of that catheter get stuck. Also, there are adjunctive strategies such as injection of dextrose to delay injection of glacial acetic acid to delay polymerization. Then there's onyx. Onyx has become really the leader as far as embolization materials for AVMs are concerned. I don't have the exact market numbers, but I believe it's now greater than 60 or 70% of AVMs are treated with onyx. A problem with onyx is it flows like lava. So sometimes a little bit more friendly flow, other times not friendly at all. And so we haven't really figured out the ideal agent. In my opinion, it does not currently exist. But these are the two different ones we have. Particles are great except for the fact that they will not be there 4 to 6 weeks later. So they will recanalize. So particles can be utilized for embolization. Just know that you're not going to really be able to see the actual particle itself. You can inject contrast and hope that the contrast and the particles are going in the same vicinity. So they're good for immediate preoperative embolization. They're very good for tumor embolization. And depending on what size particles you can use, you can get fairly good penetration. And then there are coils. Coils are really effective for dealing with fistulous components because there's really high flow, and then you can quickly pack some coils in and have them not run into the vein. And once you've created a significant stable construct, then you can go ahead and embolize with some embolic agent. So endovascular cure is not a figment of anybody's imagination, but is relatively rare. It's uncommon. And it's okay for that to be in that capacity. It's just that you need to understand what you're trying to do. Success, unfortunately, with embolization is the same classic group that can be very well treated with gamma knife radiosurgery or with open surgery. So, one or two pedicles, small, superficial AVM can be treated through any modality. And so that remains in your own mind as to what you're going to do, and a lot of different other considerations come into play, patient's age, et cetera. All those other kinds of things need to be considered. So what's the procedural protocol? So how do we do this? We establish presence as close to the nidus as is possible. Typically, we're using onyx. So what I like to do is have the catheter in the nidus if possible, or as close to the nidus as possible. If I am far away from the nidus, I will not use onyx because onyx does not like to flow. And those are the situations where I'm using NBCA more than onyx. If I get into the nidus, then I'm using onyx more than NBCA. And that's one sort of way I think about these two different agents. NBCA flows very well. Onyx does not flow very well. There are two different concentrations of onyx. You might have heard of 34 or 18. They're really not too different. The difference in onyx composition is 97% versus 95%. So it's not significantly different to allow differential flow. So once we have placed our catheter wherever that's going to be placed, the next thing we do is, my friend Pascal is not here anymore. He sort of derided the Buffalo way of doing it, and he was, very confident of the functional assessment that can be provided through intraoperative neurophysiology. The problem is, what if you're doing something in the parietal lobe, behind the sensory cortex? What about occipital lobe? What about the left hippocampus? What about Wernicke's area? What about Broca's area? A lot of different areas in these situations are not physiologically monitorable under anesthesia. That's one. Second, our tools and techniques for getting into the brain have become spectacularly good. So we have just incredible catheters and guides and wires that we can easily catheterize most areas of the brain. Certainly, stroke is finally changing that paradigm that every neurointervention needs to be under general anesthesia. Most places are doing stroke intervention without general anesthesia. Not all places, but there's a clear trend there. And it's a reflection of the better tools that we have. Listen, if we can do anything a cardiologist can do better. If they can catheterize a beating heart and deal with that, there's no reason why we cannot do that for the brain. Well, we need to be careful, absolutely, but I think there's incredible value in the information we get. And what's the biggest reason for that? The biggest reason for that is people will say, well, you can see what you're going to do angiographically if the patient's not moving. Well, the problem with that is that angiographic visualization of all the different collaterals that are immediately adjacent to the region where you're going to embolize are not visualizable angiographically because they are all flow dependent. So if you can blast a pharmacologic agent to really establish physiological non-eloquence of the region where the blood flow is going to go, it gives me a better confidence. Can complications still occur? Absolutely, because the drug you inject will kind of go same place where the contrast you inject, but it does have better bioavailability than a fleeting presence of contrast injection, and so we've certainly been strong believers. False positives are rare, false negatives do occur, but they're even rarer. The agents we talked about, NBCA. NBCA can be delayed in terms of polymerization by using glacial acetic acid. That's what we use. You can also, the other major way of dealing with NBCA is you have to dilute it with lipiodol. Lipiodol is this little oil that comes in packaged the same time. And I'll show a quick picture of that in a second. So you dilute your NBCA contrast depending on how much flow you want. So if you want no flow, and let me give you an example of no flow situation. The place where you don't want any flow is, say, you're doing vein of Galen malformation in a neonate, and you have put your NBCA catheter in that arterial pedicle right before the large venous sac of the vein of Galen. You don't want any to flow because there's such high flow there, it's going to get sucked down the vein if there's any flow at all. You want to inject and solidify immediately, and you want to do it without injecting large volumes. Well, you can then use very little lipiodol, or you could just take direct NBCA and tantalum to opacify this, because NBCA is radiolucent, and inject 100%. On the other hand, in most situations where I'm using for AVMs, my catheter just can't make all the tortuosity. I want the flow to take it. I've done my Amatol. I feel pretty good. In that case, I might use 20%, 30% NBCA. And further, you can dilute it by delaying your polymerization by adding glacial acetic acid. And typically, it's extremely small. So what I typically do if I have, say, my standard way is 30% NBCA. That way, I can my agent that I use to change that is glacial. I'll typically put in 1 or 2 drops with a 25 gauge, or with a 30 gauge needle of glacial acetic acid for 30% solution of NBCA. Then there's Onyx 18 or 34. A lot of people use different agents. I always use 34. I just find that it fills the nidus much better, and I don't use Onyx if I'm far away from the nidus. People use 18 a lot, depending on, start off with 34, make the plug and inject 18. Personally, I have not found any significant difference. I typically do 1 feeder at a time. So my embolization procedure is 1 feeder and done. And I'll inject till I get pre-desired reflux. That's how I determine where I'm going to stop. And I don't like reflux even with Onyx. Even with these new Apollo detachment catheters, I found only 50% detach. So I'm not a fan of, in fact, for AVMs, I get greatest heartburn when I'm pulling those catheters out than any other part of the procedure. So I don't like a lot of reflux, and I try to limit as much as possible. The problem with Onyx is that these procedures do take much longer than NBCA, so there's more X-ray. By the way, Steve, how long do I have? Okay, all right. So Onyx, you have to be careful, does extend radiation exposure, so there is alopecia that these patients get, especially if you're doing, that's why I don't like to do multiple procedures at the same time. I stage them out 4 to 6 weeks apart, so it allows them to recover. Another thing we do, which is sort of unique for our equipment that we have, is we have live dose monitoring in both AP and lateral planes for radiation. So we know exactly how much cumulative dose we have, and it's color-coded as well. So once we start going from blues into green or yellow, we stop. So that's another consideration. Also know that onyx, just like NBCA, is radiolucent. So that's why you've got to shake it on that little shaker to get the tantalum dispersed. So if you rapidly inject, you may not see it. Say you have a, Pascal was showing another one of his complications. Where is he? I can't deride him if he's not here. Where he had to inject onyx. You can't just inject, take it off the shelf and inject it because you won't see where it's going. You need to shake it to get the tantalum mixed in. Also know that you can't inject onyx through anything. I realized that once. It was awkward. The catheter just melted away. Literally, I was injecting it the next second I know there was no catheter at all. It just melted away. So you've got to know those things. You have to make sure these are DMSO compatible. Now, newer catheters, pretty much every manufacturer wants to make DMSO compatible. Also, you need to know what their pressure resistance is. So you can't inject NBCA through onyx through any catheter, because if their pressure tolerance is not high enough, the catheter will burst, and then your onyx will go somewhere more proximal. And so you've got to be very careful about that. Those are the problems. Oh, one other thing to note for neonates. Very small circulatory volume, same amount of DMSO that you use for an adult may result in respiratory injury in these neonates. It has been reported. So while people must say, oh, vein of Galen, I can treat it with onyx, know that there is that additional risk with DMSO. So be careful about that. We like to set up the tables just the same way as endovascular for NBCA. With NBCA, you got to be very careful. Any ionized solution will result in precipitation. So get a fresh pair of gloves. Make sure you have a lot of D5 water, non-ionized, so no saline at all should touch that. Prep your catheters, because it's very easy to mix in and then have this thing not be injectable when you're trying to inject through your catheter because you got some saline that plugged up. The tools are limited by imagination, and so always be patient, be ready to think of, be able to come out, and I'll show a couple of, start off with this case. A 60-year-old right hemiparesis comes in with this basial ganglia hemorrhage. People think, hey, maybe just hypertensive, but you can see there's this telltale sign in the ventricle which tells you where the problem is, that it's an AVM. Know that not necessarily does that mean that this venous varix is the source of the hemorrhage, because the hemorrhage is in the parenchyma, and so we attempted to catheterize this and in a delayed fashion. Again, there's no reason, unless there's a large aneurysm that you see, then you should treat it like any other ruptured aneurysm, treat it early. But otherwise, with AVMs, you do not need to treat them at the same hospitalization. Typically, what we do is we embolize them, if you're going to do that for their treatment, before they're ready to leave the hospital, typically two weeks after their presentation. So we tried to catheterize this large lenticular striate. It didn't work very well. Then we catheterized this MCA behavior catheter, and the patient was immediately hemiplegic. And so we did gamma knife radiosurgery for this patient with a cure at 4 years. Sometimes it's easier. Sometimes you have a single pedicle that's going to it, and it's truly a single pedicle. You can catheterize and then cure, such as in this case where you do multiple embolizations, multiple catheterizations, and then you have a cure after second or third. So I would sort of stop there. I can show a lot of different cases, but I wanted more to sort of a philosophical understanding of how we try to embolize, what are we thinking when we are trying to treat these conditions, and be happy to take questions. Thank you.